Picture this. You wake up one morning with a pain in your abdomen that is getting worse by the hour. You go to the hospital. A doctor in clean scrubs explains what needs to happen. An IV goes into your arm. You count backward from 10. And the next thing you know, you are waking up in a recovery room with a nurse asking if you want some water and a television playing something mindless in the corner. The whole experience of having your body opened up and repaired is, by the standards of human history, almost embarrassingly comfortable. Now, remove all of that. Remove the anesthesia, the sterile environment, the antibiotics, the monitoring equipment, the trained nursing staff, the blood bank standing by. Remove everything except the problem inside your body, a person with a sharp instrument, and the decision that something has to be done anyway. That is the situation that every surgical patient in human history faced until the mid-19th century. Not occasionally, not in extreme circumstances, every single time. For thousands of years across every civilization that ever developed surgical practice, the person on the table was awake, feeling everything. And the surgeons, if we can call them that, knew it, worked around it, and in many documented cases achieved outcomes that should not have been possible given the conditions. How they did it is one of the most extraordinary and underappreciated stories in all of human history. And it is considerably more sophisticated, more creative, and more surprisingly effective than most people assume. Start at the very beginning, because the beginning is further back than almost anyone expects. The oldest confirmed surgical procedure in the archaeological record is trepanation, which is the practice of drilling, cutting, or scraping a hole through the human skull. It appears in skeletal remains from every inhabited continent. The oldest confirmed examples date to approximately 10,000 years ago in the Neolithic period, though some researchers believe the practice is older still. Here is the part that stops people cold. Many of those ancient skulls show evidence of healing around the surgical opening. That means the patient survived the procedure. Not just for a day or a week, bone heals slowly, and the regrowth visible on some of these skulls indicates survival for months or years after the operation. In some remains, multiple trepanations were performed on the same individual at different times, each showing healing, meaning the same person survived the procedure more than once. Trepanation has been performed across cultures for reasons that probably varied. Some researchers believe it was used to treat head injuries, relieving pressure from intracranial bleeding, or bone fragments pressing on the brain. Others think it had ritual or spiritual significance, creating an opening through which spirits could enter or exit. In some traditions, possibly both explanations were simultaneously true, because the distinction between medicine and spiritual practice that modern thinking treats as categorical did not exist in most ancient cultures. Healing was spiritual. Surgery was sacred. The person cutting into your skull was probably also the person responsible for your soul. The tools used were stone in the earliest examples, flint and obsidian scrapers and borers that could achieve remarkable precision in skilled hands. Obsidian in particular has an edge that, at the microscopic level, is sharper than modern surgical steel. Some contemporary neurosurgeons have experimented with obsidian scalpels and found the cuts they produce cause less tissue trauma than metal blades. Ancient surgeons were not working with inferior tools. They were working with different tools, some of which were really competitive with modern equivalents in specific applications. But none of that addresses the central question: how did the patient endure it? The answer across cultures and centuries was pharmacological, psychological, physical, and in some documented cases, a combination of all three simultaneously. Begin with what plants could do, because ancient pharmacological knowledge was far more sophisticated than the popular image of witch doctor with herbs suggests. Opium, derived from the poppy plant Papaver somniferum, has been used medicinally for at least 5,000 years. Sumerian texts from around 3400 BCE reference the poppy plant, and Egyptian medical papyri describe its use for pain relief. Greek physicians, including Hippocrates, documented opium's properties. By the time of the Roman Empire, opium was a widely known and widely traded commodity, with clearly understood applications in pain management. The mechanism of opium is the same whether you are a Roman physician or a modern pharmacologist. The active compounds bind to opioid receptors in the brain and spinal cord, reducing the perception of pain and producing sedation. An ancient patient given a sufficient dose of opium preparation before a procedure was not experiencing the surgery the way an untreated patient would. They were sedated, their pain perception was blunted, and their physiological stress response was reduced. This is not full anesthesia, but it is not nothing either. Cannabis has a documented medicinal history stretching back thousands of years in Chinese, Indian, and Middle Eastern traditions. Ancient Chinese texts attributed to the physician Hua Tuo, who lived during the Han Dynasty around the 2nd century CE, describe a preparation called ma fei san, which translates roughly as cannabis boiling powder, used as a surgical anesthetic mixed with wine. Hua Tuo reportedly performed abdominal surgeries on patients who had consumed this preparation, which, if the accounts are accurate, represents a level of anesthetic practice that would be remarkable under any circumstances. Mandrake root from the plant Mandragora officinarum contains scopolamine and hyoscine, compounds with sedative, hallucinogenic, and analgesic properties. It was used across Mediterranean and Middle Eastern medical traditions for centuries. The plant has a dramatic historical reputation, partly because of pharmacological effect and partly because it was entangled with extensive folklore, but the underlying chemistry is real. Mandrake preparations alter consciousness and reduce pain sensitivity. Henbane, also called black henbane, or Hyoscyamus niger, contains hyoscyamine and scopolamine, and was used as a sedative and pain reliever across European, North African, and Asian medical traditions. Datura species, sometimes called thornapple or jimsonweed, contain similar compounds and appear in surgical and ritual contexts across numerous cultures. The challenge with all of these plant preparations was dose management. The difference between a therapeutic sedative dose and a lethal dose was uncomfortably small, and without standardized extraction or dosing protocols, the margin for error was significant. Ancient physicians knew this. Medical texts from multiple traditions include warnings about the dangers of overdosage and instructions for careful administration. This was not casual folk medicine. It was documented pharmacological practice with understood risks and established techniques for managing them. Alcohol deserves its own discussion because its role in ancient surgery is both real and frequently overstated. Alcohol does reduce anxiety. At sufficient concentrations, it impairs pain perception to some degree. Wine, beer, and other fermented beverages were available across virtually every ancient civilization that developed surgical practice. It would be remarkable if they were not used before procedures, and the evidence suggests they were. However, achieving surgical levels of analgesia through alcohol alone requires blood alcohol concentrations that are themselves physiologically dangerous, and the volume of wine or beer that would need to be consumed to approach that level would cause significant vomiting, which creates its own serious problems during surgery. Alcohol was likely part of the pre-surgical pharmacological toolkit in many traditions, but probably as a supplement to stronger preparations rather than as a primary agent. The combination approach is worth emphasizing here. Ancient practitioners in many traditions layered multiple agents: opium for pain and sedation, alcohol to reduce anxiety and enhance the opium effect, mandrake or henbane for additional sedative action. The combination of these substances administered together produced an effect considerably stronger than any one agent alone, and in some documented cases appears to have been sufficient to allow patients to tolerate procedures that seem impossible under those conditions. But pharmacology was only part of the picture. Physical methods of producing insensibility were also used, and some of them are considerably more alarming than anything a plant can do. Carotid compression, which involves applying firm pressure to the carotid arteries on both sides of the neck simultaneously, cuts off blood flow to the brain and produces unconsciousness within seconds. It appears in historical accounts from multiple cultures as a method of rendering patients insensible before quick procedures. The obvious problem is that prolonged compression causes brain damage, and even brief compression carries risk. It was a blunt instrument in the most literal sense. Cold, specifically the numbing effect of low temperatures on peripheral tissue, was used to reduce sensation in limbs before amputation and other extremity procedures. Packing a limb in snow or ice before operating on it reduces blood flow and nerve conductivity in ways that diminish pain sensation. By the way, if you want to go even deeper into the secret lives of ancient humans, I just launched a full course called The Secret Lives of Ancient Humans. 10 modules, 3+ hours of content covering everything we never talk about on YouTube. What they feared, how they communicated, what hunted them, and much more. Plus an exclusive PDF guide included. Link in the description. See you inside. This technique was used in cold climate cultures and was observed by military surgeons in later centuries, who noted that casualties in cold weather were sometimes easier to treat because the cold itself had produced a degree of local analgesia. Nerve compression, distinct from carotid compression, was also used. Applying strong, sustained pressure to a nerve proximal to a surgical site, above the area being operated on, can reduce sensation in the tissue beyond the compression point. This is a real neurological phenomenon and was used in some traditions as a targeted local technique. Tourniquets, used to control blood loss during limb amputations, had the secondary effect of compressing nerves along with blood vessels, contributing to reduced sensation in the operative field. Ancient surgeons may not have understood the neurological mechanism, but they could observe the practical effect. None of these physical methods produced anything resembling modern general anesthesia. What they produced, in combination with pharmacological agents, was a reduction of sensation and consciousness significant enough to make surgery survivable from a psychological standpoint. The patient was still in pain, but the pain was managed enough and the patient was sedated enough that the procedure could be completed. Here is a fact that changes the entire frame of this conversation. Ancient surgeons were fast. Deliberately, systematically, obsessively fast. In the absence of reliable pain elimination, speed was itself a form of mercy. The faster a procedure was completed, the less the patient suffered, the less blood was lost, the lower the risk of shock, and the greater the overall chance of survival. Ancient surgical training, across cultures, emphasized speed as a primary virtue in ways that modern surgical education does not need to, because modern surgical education has anesthesia. Roman texts on surgery describe speed as the foremost quality of a skilled surgeon. Indian Ayurvedic surgical texts similarly emphasize rapid, decisive technique. Medieval European surgical manuals include descriptions of successful amputations completed in under a minute by experienced operators. The 19th century British surgeon Robert Liston, operating in the period just before anesthesia became available, was famous for being able to amputate a leg in under 2.5 minutes. He practiced his incisions obsessively and had developed techniques specifically designed to minimize operative time. This was not showmanship. It was the most humane thing he could offer his patients given the available technology. The design of ancient surgical instruments reflects this imperative. Instruments recovered from surgical contexts across ancient Egypt, Greece, Rome, and India are notably sharp, precisely made, and ergonomically designed for rapid, controlled movement. The Roman surgical instruments recovered from Pompeii, preserved by the eruption of Vesuvius in 79 CE, include scalpels, forceps, probes, hooks, and specula, of a quality that surprises most people who see them because the quality of craft reflects an underlying understanding of what surgical tools need to do. The Sushruta Samhita, an ancient Indian text attributed to the physician Sushruta and dated to somewhere between 600 BCE and the early Common Era depending on which sections are being discussed, is one of the most remarkable medical documents in human history and deserves considerably more attention than it typically receives in Western accounts of surgical history. The Sushruta Samhita describes over 300 surgical procedures, more than 120 surgical instruments, and covers wound management, fracture treatment, urinary procedures, and a detailed methodology for what we now call rhinoplasty, reconstructive surgery on the nose. The text describes taking a flap of skin from the patient's forehead, rotating it down to reconstruct a damaged or amputated nose, and securing it in place. A procedure that is recognizably ancestral to techniques still used in reconstructive surgery today. The text also addresses pain management directly. It describes the use of wine before procedures to produce insensibility and reduce fear. It distinguishes between different states of intoxication and which states are appropriate for surgical intervention. It addresses the psychological preparation of patients before surgery, including the importance of reducing fear through reassurance and ritual. It describes the role of assistants in holding and restraining patients, not only for physical control, but for psychological support. This is a sophisticated, comprehensive framework for managing surgical pain and patient welfare under the constraints of pre-anesthetic medicine. It did not appear from nowhere. It represents centuries of accumulated experience and observation codified into a transmissible medical tradition. Ancient Egypt's contributions to surgical knowledge are documented primarily through the Edwin Smith Papyrus, one of the oldest known medical texts, dated to around 1600 BCE, but believed to be copied from an earlier source perhaps 1,000 years older. The text describes 48 cases involving injuries, primarily to the head and upper body, with careful clinical descriptions of examination, diagnosis, treatment, and prognosis. What is striking about the Edwin Smith Papyrus is its rationalism. Cases are categorized as conditions that can be treated, conditions that might be treated with effort, and conditions that cannot be treated and where the physician should withdraw. This is clinical triage in a medical culture that is nearly 4,000 years old. The text does not invoke spirits or demons as causes of injury. It describes physical mechanisms of injury and physical responses to treatment in language that a modern trauma surgeon would recognize as medically coherent. Egyptian surgical practice included treatment of infected wounds with honey, which has antimicrobial properties, and was used across multiple ancient medical traditions for wound management. It included the use of moldy bread on infected wounds, a practice that predates the understanding of antibiotics by millennia, but which we now understand was likely working because molds can produce penicillin-like compounds. Ancient Egyptians were doing empirical medicine. They did not know why it worked, they observed that it worked, and they kept doing it. The Greek tradition, culminating in but not limited to the Hippocratic corpus, contributed the framework of systematic clinical observation that influenced Western medicine for 2,000 years. Hippocratic texts describe wound closure, fracture management, joint dislocation reduction, drainage of fluid collections, and a range of other procedures with careful attention to both technique and patient management. The Hippocratic tradition also documented the use of opium and other substances for pain relief, and described the importance of patient positioning and assistant involvement in surgical procedures. The role of assistants in ancient surgery is worth pausing on, because it was considerably more important than modern surgical assistants, for reasons that should be obvious. When your primary pain management strategy is pharmacological sedation that falls well short of unconsciousness, the person on the table needs to be physically held in position by other people. Ancient surgical texts across traditions describe the number of assistants required for different procedures and their specific positioning responsibilities. Some texts describe the qualities required of surgical assistants: steadiness, strength, the ability to maintain composure while holding down a patient who is experiencing pain, and the discipline not to respond to screaming in ways that would compromise the procedure. This was specialized work requiring specific psychological qualities, and it was taken seriously as a component of surgical practice. Medieval Islamic medicine deserves particular attention because the period between roughly the 8th and 13th centuries represents a high point in surgical sophistication that is often overlooked in popular histories. That jump from ancient Greece to Renaissance Europe. Al-Zahrawi, known in the West as Albucasis, was a physician working in Moorish Spain in the 10th and 11th centuries, whose encyclopedic medical text, the Kitab al-Tasrif, included a volume on surgery that was used as a reference throughout Europe and the Islamic world for centuries. Al-Zahrawi described and illustrated over 200 surgical instruments, many of which he claimed to have invented or refined. He described cauterization as a surgical tool, the use of catgut sutures derived from animal intestines for internal wound closure, and techniques for lithotomy, removal of bladder stones, that represented the state of the art for his era. The use of catgut sutures is worth noting because it represents a solution to one of the critical problems in pre-antibiotic surgery: the need for internal sutures that would be absorbed by the body rather than requiring removal and risking infection. Catgut, despite the name, typically comes from sheep intestine and is gradually broken down by the body's enzymes after wound closure. Al-Zahrawi's documentation and promotion of this technique influenced surgical practice for centuries. Ibn Sina, whose work was translated into Latin as Avicenna, and whose canon of medicine served as a primary medical reference in European universities into the 17th century, described the use of oral opium preparations and inhalation of narcotic vapors for surgical pain management. He documented what he called soporific sponges, sponges saturated with opium, henbane, mandrake, and other compounds that patients would inhale before procedures. The soporific sponge appears across medieval medical literature in both Islamic and European traditions, and represents an attempt to standardize delivery of sedative agents in a way that improved consistency of effect. European medieval surgery operated within a complicated institutional context. The Church, which controlled much of European education through this period, had a complex relationship with surgery that is often oversimplified. The famous prohibition Ecclesia abhorret a sanguine, the Church abhors blood, which is sometimes cited as evidence that religion suppressed surgical practice, was actually directed at clergy performing surgery rather than at surgery in general, and its application was inconsistent across time and place. Surgery continued to be practiced, documented, and taught throughout the medieval period. The distinction between physicians and surgeons in medieval European practice was socially significant. Physicians were educated at universities and managed internal medicine, while surgeons were frequently members of craft guilds working alongside barbers, with considerably lower social status despite performing work that was at least as technically demanding. The surgeon-barber relationship, which gave rise to the red and white pole that still marks barbershops today, representing blood and bandages, tells you something about how surgery was categorized socially, even as the practice itself was sophisticated. Medieval European surgery included amputation, hernia repair, wound management, treatment of cataracts, and lithotomy, among other procedures. Surgeons working in military contexts, campaign surgeons treating battlefield injuries, accumulated experience at a pace impossible in civilian practice. And military surgical traditions drove advances in technique throughout the medieval and early modern periods. Pain management in medieval European surgery combined the pharmaceutical traditions inherited from Greek and Islamic sources: opium, henbane, mandrake, alcohol, with physical restraint, prayer, and the deliberate cultivation of speed. Some medieval surgical texts describe the psychological preparation of patients before procedures in terms that align with what we would now call anxiety reduction techniques: reassurance, distraction, and the projection of calm confidence by the operator. The Inca civilization in pre-Columbian South America provides one of the most striking examples of surgical sophistication outside the Eurasian tradition. Archaeological evidence from Peru and Bolivia includes skulls with trepanation marks showing healing, in quantities and with survival rates that are remarkable by any standard. Analysis of hundreds of trepanned skulls from Inca and pre-Inca sites has found that survival rates improved dramatically over time, suggesting that practitioners were learning from experience and refining technique. The earliest examples in the sample showed survival rates around 40%, already significant for a procedure of that complexity. By the late pre-colonial period, survival rates approaching 90% have been suggested by some analyses of specific sites, which compares favorably with outcomes from European trepanation well into the 19th century. Inca surgeons used coca leaves, which contain cocaine as an active compound, in their medical practice. Cocaine is a local anesthetic, a real, pharmacologically effective one, which is why it became the basis for the first local anesthetic agents developed in the 19th century. Applied topically to tissue, cocaine preparations produce local numbing. Applied during trepanation, they would have reduced sensation in the scalp and underlying tissue being operated on. Some researchers have proposed that Inca practitioners may have used coca preparations directly at the surgical site, And while direct documentation is limited due to the destruction of pre-Columbian records during Spanish colonization, the pharmacology is sound. The transition from pre-anesthetic surgery to modern anesthesia happened quickly by historical standards. The first public demonstration of ether anesthesia occurred at Massachusetts General Hospital on October 16, 1846, a date known in medical history as Ether Day. Within a year, ether had been used in surgical procedures on multiple continents. Within a few years, chloroform had been added as an alternative agent. The transformation of surgery from an experience of conscious agony to one of managed unconsciousness happened within a single decade. The speed of adoption tells you something important. The need had always been there, understood by every surgeon and every patient who had ever been part of a pre-anesthetic procedure. When a solution appeared, the medical world moved toward it with a speed that reflects how urgently it had been needed. But here is what the rapid adoption of anesthesia also reveals. Every surgical tradition that existed before 1846 had developed its practices, its techniques, its pharmacological combinations, and its psychological approaches within the constraint of patient consciousness. Every advance in ancient and pre-modern surgery happened despite the fact that the person being operated on was awake and experiencing what was being done to them. The sophistication of ancient surgical practice was built on top of that constraint, around it, in spite of it. Ancient surgeons could not eliminate pain, so they reduced it, managed it, worked around it, and proceeded anyway. They did trepanation in the Neolithic. They performed rhinoplasty in ancient India. They removed bladder stones in medieval Europe. They amputated limbs in dozens of cultures across thousands of years. Their patients, heavily dosed with whatever pharmacological toolkit was available, restrained by multiple assistants, operated on by surgeons whose speed had been honed to something approaching art form, survived these procedures in numbers that should not be possible under those conditions and frequently were. The next time you sit in a clean hospital room watching an IV drip, counting backward from 10, think about the person on the table in ancient Rome, or medieval Persia, or pre-Columbian Peru, who also needed what you needed, someone to fix what was broken inside them, and had to trust that the person holding the knife, with nothing but plants and speed and skill and the sheer force of accumulated human knowledge, was going to get it done. They often did. That is not a footnote in the history of medicine. That is the whole story, playing out across 10,000 years before the chapter you are living in had even begun.